Welcome to the deep dive. If you're joining us today, you are exactly who we have in mind when we prepare these sessions. You are the learner.
Exactly.
You might be a medical student staring down the barrel of your final exams, or, a junior doctor desperately trying to revise your medico-legal principles before a rotation.
Or maybe even a senior clinician wanting to just solidify those forensic foundations.
Right. Whoever you are and wherever you're listening from, we are thrilled to have you with us. Today, we're taking a highly specific, highly conceptual journey behind locked doors.
Yes.
We're stepping out of the familiar, brightly lit corridors of the traditional hospital ward and into a very different, highly scrutinized, and frankly, often chaotic environment, the intersection of medicine and police custody.
It is an incredibly fascinating space to work in. But it demands a completely different psychological and clinical mindset from the healthcare professional.
Yeah, the traditional rules of patient engagement, they get warped by the environment.
They do. But your ethical obligations remain rigidly intact.
Exactly, and that tension is what we are going to explore today. Now, to be exceptionally clear right at the top, our mission with this deep dive is to build a high-yield, conceptual framework around police custodial healthcare.
We're using Chapter 16 of the foundational text, Simpson's Forensic Medicine, as our structural spine.
But, and this is a crucial disclaimer, this conversation is a conceptual companion to support you in reading that text. It is absolutely not a regurgitation of the book, nor is it a replacement for actually sitting down and reading the chapter yourself.
Our goal here is to anchor these complex concepts in your memory, to help you recognize the clinical patterns, and to connect those physiological findings with the stark medico-legal realities of the environment.
We want you to read the chapter alongside this analysis.
To really set the scene for you, I want you to mentally place yourself in the environment we're discussing. Imagine a sparse, purely functional clinical examination room.
Right.
There are no expansive windows letting in natural light, no soft, calming ambient lighting, no comfortable waiting areas. You are situated deep within the architecture of a brick and concrete police station.
The ambient noise is entirely different there.
It really is. You hear the heavy metallic clatter of secure doors slamming shut and electronic locks engaging down the corridor. You hear the muffled shouts of frustrated or intoxicated individuals.
Yeah.
In this specific environment, the core philosophical theme you must hold onto the anchor for everything we will discuss is independence within confinement.
Independence within confinement.
Exactly.
Yeah.
Your ethical medical practice, your clinical autonomy, and your fundamental unwavering duty of care to the patient sitting in front of you do not pause simply because you crossed the custody threshold.
Right.
If anything, those principles are tested more rigorously in that small room than almost anywhere else in the medical field.
I love that phrase, independence within confinement. It perfectly frames the immense responsibility placed on the clinician. We're going to focus heavily on clinical reasoning and differentiation today, moving far beyond mere rote memorization.
Absolutely.
So let's start by establishing the parameters of this world. When we use the term police custody in this specific medical and legal context, what exactly are we defining? We aren't talking about long-term federal prisons here, are we?
No, we are looking at a very specific acute window. In the context of our source material, police custody refers strictly to short-term detention.
Okay.
This is the period when an individual is in the immediate care of a police service that is actively investigating an allegation of a crime. They have just been arrested. We are not discussing the long-term sentence prison population.
Though, of course, their demographic and health profiles overlap significantly.
They do overlap, yes. But specifically, in jurisdictions like England and Wales, which the text uses as its primary framework, this initial custody period is strictly regulated. It is typically limited to a maximum of 24 hours.
So the police can't simply hold someone indefinitely.
Exactly. There are exceptions, of course, where judicial permission is granted by a magistrate to extend that time for complex investigations. Or if the authorities are dealing with specific severe offenses like terrorism, where standard custody time limits are superseded by specialized anti-terror legislation. But generally, you are looking at a 24-hour ticking clock.
And why is that specific 24-hour time frame so critical for us to understand from a purely medical and physiological standpoint? Why does the clock matter to the doctor?
Because that immediate post-arrest window is arguably the most physiologically and psychologically volatile period a human being can experience outside of acute trauma.
Right. They've just been arrested.
You're dealing with individuals who have just been forcibly removed from their chosen environment, often abruptly, sometimes violently. Their acute physiological stressors are peaking.
Their sympathetic nervous system is in overdrive.
Massive catecholamine release, skyrocketing cortisol levels. In England and Wales, the Police and Criminal Evidence Act of 1984, which you will frequently hear referred to as PACE, exists specifically to mandate the early identification of risk factors in this exact highly volatile window.
And PACE was born out of a historical need to heavily regulate police powers, right?
Yes, following various historical abuses. But medically, it establishes a profound legal precedent. The law recognizes that because the state has forcibly stripped this person of their liberty, the state thereby assumes absolute, total responsibility for their physical safety and medical well-being.
So if they die or are harmed in that cell, the state has failed its fundamental duty.
Exactly.
Let's contextualize that profound responsibility by looking at exactly who is sitting in these cells. I don't want to just rattle off statistics. I want us to build a clinical picture of the average patient you might encounter. But man, the data from the source is undeniably staggering.
It paints a very clear picture.
We are looking at a population that is roughly 85% male with a mean age of 34. But it's the toxicological and clinical profile that really demands your attention as a practitioner.
Yeah, I'd list those out.
Look at these numbers. 34% are dependent on heroin, 34% are dependent on crack cocaine, 25% are dependent on alcohol.
And furthermore, nearly a third of them are totally disenfranchised from standard health care. They aren't even registered with a primary care physician.
When you hear those numbers, you immediately recognize a population existing in extreme multifaceted vulnerability.
You do. And to make sense of this clinically, and to help our listeners anticipate the pathology they will see, we can use a conceptual framework we'll call the vulnerability multiplier.
The vulnerability multiplier. Okay, let's unpack this.
In the custody environment, we essentially divide a patient's health issues into two broad interacting categories. First, you have what we call the forensic healthcare issues. These are the acute, chaotic factors directly linked to the arrest itself. Illicit drug intoxication, acute and profound alcohol issues, and acute decompensating mental health crises.
Okay, and the second category?
Second, you have the general healthcare issues. Asthma, type 1 or type 2 diabetes, epilepsy, severe cardiovascular disease, chronic infections.
Right. The general issues are the chronic conditions that anyone riding the subway or walking down the street might have.
Exactly. But here is where the multiplier effect turns deadly. The chaotic lifestyles inherently associated with those forensic issues, the daily grind of substance dependence, the frequent homelessness, the systemic poverty lead directly to the abysmal management of those general issues.
So there's often zero compliance with routine preventative treatments.
None. The source highlights a terrifying statistical reality. Roughly 55% of all police detainees have active documented medical conditions, but only 4% have access to their necessary medication while in custody.
4%, that's incredibly low.
And let's be realistic, of those who do manage to have their medication brought to the station, a significant portion weren't taking it regularly or correctly prior to their arrest anyway.
Let's paint a clinical vignette to really solidify what that multiplier looks like at 2 a.m. in a police station.
Perfect.
Imagine a 34-year-old male detainee. He has unmanaged type 1 diabetes. He is also physically dependent on heroin and uses crack cocaine heavily. He is arrested after a chaotic foot chase.
So he's highly stressed.
His adrenaline is through the roof. He hasn't taken his insulin in 2 days. His blood glucose is wildly unstable. And he is now sitting in a locked concrete cell beginning to sweat as the heroin starts to leave his receptors.
That is a perfect catastrophic storm for morbidity and mortality behind bars.
It is a physiological time bomb. And that scenario puts an immense, almost unfair pressure on the frontline police personnel, the custody sergeants and detention officers.
To spot these complex intersecting risks.
Right, and they are not doctors.
Which underscores the absolute non-negotiable necessity of having a highly trained, high-quality healthcare team available to intervene, triage, and manage that time bomb before it goes off.
Which perfectly transitions us into the actual delivery of that care. How does this system function? The delivery of custodial healthcare varies wildly depending on where you are in the world, but the fundamental scope of practice, the core mandate of the clinician, remains consistent.
Healthcare professionals in this environment wear two very distinct hats.
Right. They provide general medical services, acting like a GP or an ER doc, treating acute illnesses and managing crises. And they facilitate forensic and police-related processes.
But before we get into the weeds of those processes, let's clearly define the terminology, because examiners love to trip students up on this. We need to firmly anchor the differentiation between clinical forensic medicine and forensic pathology.
It is a vital foundational distinction.
Clinical forensic medicine is strictly the practice of forensic medicine in the living. It is dynamic. It is carried out by forensic physicians, specialized custody nurses, and advanced custody paramedics.
They are dealing with breathing, moving, talking, and sometimes fighting patients.
Exactly. Their work is preventative, diagnostic, and evidentiary. Forensic pathology, on the other hand, deals exclusively with the dead.
The forensic pathologist's domain is the mortuary, determining the exact cause and mechanism of death via autopsy.
Right. If the practitioner of clinical forensic medicine fails in the custody suite, the patient ends up on the table of the forensic pathologist.
So for the practitioner of clinical forensic medicine standing in that sparse examination room, what are the specific, unique forensic duties they are tasked with beyond just handing out an inhaler or checking blood pressure?
Their forensic remit is broad and carries heavy legal weight. They are routinely called upon to meticulously document injuries, both for suspects who claim they were assaulted by police or others, and for complainants or victims of crime.
They assess drivers suspected of profound intoxication who perhaps cannot complete a standard breath test.
But crucially, heavily uniquely to this environment, they conduct formal medical assessments to determine a detainee's fitness to be interviewed by the police and their fitness to be detained or formally charged.
And they may also be legally responsible for forensic sampling. Let's pause on that. Forensic sampling. That sounds incredibly clinical, but practically, what does that actually look like for the clinician?
It involves the intimate gathering of biological evidence. This could mean drawing blood under highly controlled conditions for toxicology screens in a driving offense.
Or it could mean taking intimate swabs, genital, anal, or oral, from a suspect in a sexual assault case, or gathering DNA material from fingernail scrapings.
And this requires rigorous adherence to the chain of custody. If you mislabel a vial or break the chain of custody protocol, you don't just compromise a medical chart.
You potentially collapse a major criminal trial. And that brings up the massive looming ethical tightrope of this environment, the medico-legal pillars of practice. We established earlier that ethical practice doesn't stop at the door. The foundational rule here is that consent and confidentiality apply in the custody cell exactly as they do in a standard private medical clinic,
with very few, highly specific, legally mandated exceptions.
If we connect this to the broader legal picture, the gravity of this concept cannot be overstated. When you step into that cell, you must actively remind yourself you are not an agent of the police force.
You are an independent, autonomous clinician. Any breach of patient confidentiality, for example, casually sharing a detainee's mental health history or substance abuse details with the investigating officers without the explicit, informed consent of the detainee, must be rigorously legally justified.
It must be meticulously documented.
And the specific legal or safeguarding reasons for that breach, such as a direct, immediate threat to the life of a child or a credible threat of terrorism, must be explicitly recorded in your contemporaneous notes.
I want to push back on that a little bit because textbook ethics are great, but let's look at the reality of the room. The police officer is standing right outside the door. They just wrestled this suspect to the ground an hour ago. They are under pressure to close a case.
It's a high-pressure scenario.
The officer pulls you aside and says, "Doc, we need to interview him now. Is he faking this chest pain to avoid answering our questions?"
How does a junior doctor maintain that strict independence when the operational pressure from law enforcement is literally breathing down their neck?
That is the exact friction point every custodial clinician faces. And it requires profound professional backbone. You have to compartmentalize the environment. You answer the officer politely but firmly, referencing your clinical boundaries.
So you stick strictly to the medicine.
If the patient has chest pain, your only concern is the electrocardiogram, the troponin levels, the cardiac risk factors. You assess the patient. If the patient is medically unfit for an interview because of acute coronary syndrome, you state the patient is medically unfit for interview.
You do not need to diagnose them to the officer.
Yeah.
You simply provide the operational conclusion based on your confidential medical assessment. Your documentation is your shield, because that documentation is going to be scrutinized intensely.
It must be able to withstand hostile external legal review, potentially years later in a criminal court, or worse, in a coroner's inquest if the patient dies.
Political autonomy is your absolute paramount directive. The healthcare professional serves the patient, not the criminal investigation.
If a detainee confides in you about an injury they sustained, but explicitly refuses to let you share that medical information with the officers investigating their case, your primary foundational duty of confidentiality remains entirely intact.
Provided there are no immediate, life-threatening safeguarding overrides.
That is a phenomenal real-world anchor for our listeners. Let the documentation be your shield. Remember the overarching theme: independence within confinement.
It's crucial.
Let's shift gears now and dive deep into the clinical pathology you are actually going to face in these cells. We touched on the vulnerability multiplier, but we need to thoroughly unpack the twin clinical threats that dominate this landscape: intoxication versus withdrawal.
This specific dichotomy requires incredibly sharp, anticipatory clinical reasoning. You have to clearly differentiate the timelines, the physiological mechanisms, and the distinct trajectories of risk.
Let's start with intoxication.
Intoxication, meaning the drug or alcohol is currently active in the bloodstream at high levels, presents an immediate acute risk. The primary threat here is cardiorespiratory arrest.
The substances, whether they are massive quantities of alcohol, heroin, or benzodiazepines, are actively binding to receptors and severely depressing the central nervous system,
Telling the brain to stop breathing. Or, conversely, massive doses of stimulants like cocaine are overstimulating the cardiovascular system, risking acute myocardial infarction or hemorrhagic stroke.
Withdrawal, however, operates on a delayed timeline. It is the physiological rebound, and it is equally, if not more, potentially fatal. Let's focus on withdrawal, because the source specifically points out withdrawal from alcohol, heroin, and benzodiazepines as massive life-threatening dangers in custody. People often think of heroin withdrawal as the worst, but physiologically, alcohol withdrawal syndrome, or AWS, is the one that can literally kill you through seizures and delirium tremens.
Let's explore the pharmacology briefly. Why does removing alcohol kill?
Right.
It comes down to neurotransmitter adaptation. Alcohol is a central nervous system depressant. It enhances the inhibitory neurotransmitter GABA and suppresses the excitatory neurotransmitter glutamate.
So when someone drinks heavily and chronically, the brain compensates by downregulating GABA receptors and massively upregulating glutamate receptors just to maintain baseline function.
Exactly. When you suddenly remove the alcohol, say, by locking the person in a cell for 12 hours, that artificial suppression is gone. The brain is left with a massive surplus of excitatory glutamate and too few inhibitory GABA receptors.
The central nervous system essentially redlines.
It hyperexcites, leading to tremors, severe autonomic instability, tachycardia, hyperthermia, and ultimately status epilepticus, continuous fatal seizures.
That physiological understanding completely changes how you view a shaking detainee. To assess and quantify these specific threats, the clinical community relies on standardized flu sheets. Examiners will expect you to know these.
For alcohol, we utilize the CIWAR scale, the Clinical Institute Withdrawal Assessment for Alcohol.
But I want us to really zoom in and deeply explore the tool used for opioid withdrawal, the Clinical Opiate Withdrawal Scale, known universally as the CIWS. The granular detail required to properly utilize this scale is fascinating.
The CIWS scale is a brilliant piece of clinical design because it explicitly forces the clinician to look for objective, measurable physical signs of physiological rebound,
rather than relying solely on the subjective complaints of the detainee.
This objectivity is utterly crucial in a custodial environment where secondary gain, for instance, a detainee exaggerating symptoms in the hope of getting a prescription for methadone or buprenorphine, may be a significant factor.
Exactly. Let's walk the listener through a simulated assessment. Let's say it's 3 a.m. You are called to cell number 4. The detainee has been in custody for 14 hours since their last heroin use. You walk in. What are you actually looking for to score them on the CIWS scale?
First, you check their vitals. The resting pulse rate spikes. The locus coeruleus in the brainstem is firing rapidly, dumping noradrenaline into the system. We're looking for pronounced tachycardia.
Then you observe for sweating. But the scale is highly specific. It notes this must be sweating that is not accounted for by the room temperature or recent physical activity. Are there visible beads of sweat forming on their brow or upper lip while they are just sitting motionless in a cool concrete cell?
Precisely. You are hunting for inappropriate autonomic responses. Next, you observe their general motor activity and restlessness. Can they sit still in the chair? Or are they constantly shifting their weight, pacing the cell, unable to find a comfortable position?
Then, you look closely at their eyes. Pupil dilation, or mydriasis, is a classic hallmark sign of opioid withdrawal. Opioids cause pinpoint pupils. Withdrawal causes the opposite.
The CLWS scale asks you to quantify it. Are the pupils slightly dilated? Or are they so profoundly dilated that only a thin rim of the colored iris is visible against the massive black pupil?
That's a vivid clinical image, only the rim of the iris visible. As you continue the assessment, they might complain of severe bone or joint aches, a deep, diffuse pain.
You might observe a constantly runny nose, known clinically as rhinorrhea, or excessive tearing of the eyes.
You must ask about and observe for gastrointestinal upset, which can range from mild stomach cramps to multiple severe episodes of vomiting or explosive diarrhea as the smooth muscle of the gut, previously paralyzed by opioids, goes into spasm.
And you must not overlook the tremor. You ask the detainee to hold out their hands, fingers spread. Are you seeing a slight, barely observable tremor or gross, uncontrollable muscle twitching?
You'll also likely observe frequent uncontrollable yawning, significant underlying anxiety, or severe irritability. And finally, one of the most undeniable objective signs, piloerection.
Gooseflesh skin.
The term cold turkey literally derives from this sign.
The scale explicitly requires you to check if the piloerection of the skin can be felt, or if the tiny hairs are visibly standing up on the patient's arms.
Taking the time to meticulously assess this isn't just a bureaucratic box-ticking exercise to fill out the medical notes. It is a critical diagnostic process that directly dictates the patient's clinical pathway.
The total CLWS score determines whether this detainee needs immediate emergency transfer to a hospital, or, if your jurisdiction allows it, if they are an appropriate candidate for a buprenorphine induction right there in the custody suite to manage the withdrawal safely.
And that brings up a vital pharmacological point. Why buprenorphine?
Buprenorphine is a partial mu-opioid agonist. It has an incredibly high affinity for the opioid receptors in the brain, meaning it will aggressively kick off any remaining heroin or fentanyl.
However, it has low intrinsic activity. It turns the receptor on just enough to completely stop the agonizing symptoms of withdrawal, but not enough to cause a euphoric, high, or dangerous respiratory depression.
But if you give it too early, before the patient is in moderate withdrawal, as proven by a high CLWS score, the buprenorphine will rip the remaining illicit opioids off the receptors and throw the patient into precipitated withdrawal.
Which is sudden, explosive, and agonizing.
Therefore, the CLWS assessment must be flawlessly accurate. That is the essence of clinical reasoning in this environment. You meticulously identify the pattern to precisely dictate the life-saving action.
Now, while we are focused on the severe health problems detainees face, we must also address the physical trauma of the arrest itself, the hidden, often misunderstood dangers of restraint injuries.
Yes, the text brings up a point that I found surprising from an academic standpoint. It notes that there is a significant, frustrating lack of robust, peer-reviewed medical data regarding the long-term clinical outcomes of various police restraint and control techniques.
It is a massive blind spot in forensic epidemiology.
Currently, the medical community relies far too heavily on anecdotal media reports or highly publicized sentinel events, which is deeply problematic for establishing evidence-based medicine.
But the crucial insight for the clinician to understand here is the systemic underreporting of harm.
Think about the mechanics of public order policing. Individuals who are exposed to riot control agents like tear gas, powerful irritant sprays like PIVA or pepper spray, water cannons, or even physical restraint during a protest, but who are not subsequently formally arrested and brought to a custody suite, rarely seek official medical help.
They go home, they wash their eyes out, they nurse their bruises, they do not officially report their injuries to a hospital database.
Therefore, the injury data we meticulously gather from within the custody suite represents only the very tip of a much larger iceberg regarding the true public health impact of these law enforcement techniques.
That concept of the hidden injury transitions us perfectly into our next major area of focus: risk assessment, risk identification, and the concept of diversion. We are looking at what is often referred to clinically as the golden hour of custody.
As soon as those heavy custody doors lock behind the detainee, the metaphorical clock starts ticking loudly. The initial risk assessment has to happen immediately upon arrival.
We are looking at a highly structured two-part harmony here, structurally documented on a standardized risk assessment pro forma.
The first part relies on the direct questioning of the detainee by the booking officer. Do you have any ongoing medical conditions? Have you consumed any alcohol or illicit drugs today? Do you have any diagnosed mental health problems or recent thoughts of self-harm?
And the second part of that harmony is the custody officer's independent visual objective assessment. They are trained to look beyond the answers.
Does this detainee appear visibly unwell, regardless of what they're saying? Are they sweating profusely? Were they visibly injured during the physical arrest? With significant force, or were handcuffs utilized to bring them in?
But this two-part system relies on a functional patient. This raises an incredibly important high-risk clinical question. How do we accurately determine the truth? How do we find the hidden medical danger when the patient in front of us might be highly uncooperative, heavily intoxicated, aggressively hostile, or simply neurologically incapable of answering the questions?
The source text highlights a very specific, critical red flag on the booking documentation. It all comes down to the signature box.
At the end of the risk assessment, the detainee is asked to sign the form to confirm their answers. If the custody officer is forced to physically write the word incapable in that signature box,
Then that must be treated as an immediate flashing red light for the medical team. An incapable detainee, someone who cannot comprehend or physically sign a simple form, cannot have their medical risk accurately triaged by a lay police officer.
that documentation of incapacity mandates immediate, urgent healthcare professional involvement.
You must step into that cell to assess exactly why they are incapable. You cannot assume it is just alcohol. Is it a massive overdose of sedative drugs? Is it a traumatic brain injury sustained during the arrest? Are they in a post-ictal state from an unwitnessed epileptic seizure in the back of the police van?
Incapacity is a symptom, not a diagnosis.
Exactly.
And while the interaction in custody is usually just a single, brief consultation, the text places a heavy emphasis on the fact that it shouldn't be viewed merely as a bureaucratic hurdle. It shouldn't be a missed opportunity.
Absolutely not. For a vast swath of these highly marginalized individuals, this brief, compulsory medical check inside a police cell might be the absolute only contact they have with the formal healthcare system for years.
They don't go to GPs. They avoid hospitals until they're dying.
This is a rare, captive window to intervene in a profoundly chaotic life trajectory.
In public health terms, we call them brief interventions. The clinician can utilize rapid, evidence-based screening tools. For example, using the fast alcohol screening test or the alcohol use disorders identification test.
Identifying a severe, life-threatening substance problem during those 15 minutes of medical clearance can trigger an immediate referral to an independent drug and alcohol worker embedded right there in the station.
You might literally be changing the trajectory of their life upon their release, moving them from the criminal justice pathway onto a therapeutic public health pathway.
It is the absolute front line of preventative medicine. But, as we know, despite these elaborate systems, despite the risk assessments and the medical presence, terrible tragedies still occur behind those locked doors.
This brings us to a grim but absolutely essential topic: deaths and harm in police custody. The clinical and legal stakes simply do not get higher than this.
The text explicitly outlines the big five pathways, the five main physiological categories that cause death either within the cell or shortly following release from police custody.
For the sake of our learners taking notes, let's categorize them clearly. Number 1, profound alcohol and drug intoxication. Number 2, severe alcohol withdrawal. Number 3, self-harm and suicide. Number 4, restraint-related injuries and positional asphyxia. And number 5, acute natural disease, like a massive myocardial infarction. When you review that specific list of the big five from a clinical epidemiological perspective, what is the unifying theme that should immediately stand out to the practitioner?
Well, what glaringly stands out to me is that the first three causes, intoxication, withdrawal, and self-harm, are overwhelmingly the most common preventable causes of death.
Precisely. While sudden natural disease is always a major, unpredictable factor in any high-stress population, profound intoxication, untreated withdrawal, and suicide in a monitored cell are clinical pathways that a vigilant medical system can and should actively intercept.
Because of the profound total responsibility the state holds over detained individuals, any death in custody is treated as a catastrophic systemic failure. It triggers an automatic, independent, and notoriously rigorous legal investigation. In the UK, for instance, this is conducted by the Independent Office for Police Conduct, the IOPC.
The coroner will dissect every single entry in your clinical notes.
And the statistics these investigative bodies gather highlight a disturbing trend. Alongside the direct deaths that occur physically within the cell, suicides that occur immediately following release from custody, and deaths where the cause remains unascertained represent a massive ongoing burden on the system.
Which means the initial medical assessment simply has to be flawless. There is no margin for error. And there is one specific, highly lethal clinical trap mentioned in the text that is frankly terrifying for any junior doctor working night shifts.
Yes, the RTC masking effect.
I want to build a detailed narrative scenario for our listeners to really anchor this concept in their minds. We'll call this deadly trap the RTC masking effect.
Please, set the scene.
Imagine you are the custody doctor on duty. It is 2 a.m. on a Saturday. A detainee is brought into the suite. They've just been arrested for drink driving after a high-speed road traffic collision, an RTC.
They crash their car head-on into a concrete lamppost, the airbags deployed.
The police drag them in, and the detainee is wildly belligerent, violently slurring their words, stumbling over their own feet, and profoundly drowsy. The entire room smells overwhelmingly of cheap alcohol.
The clinical trap is now perfectly set. The pathological framework required here demands intense, almost paranoid clinical discipline. The most obvious, glaring presentation is severe alcohol intoxication.
The arresting police officers confidently tell you it's intoxication. The detainee, in their confused state, probably believes it's intoxication.
But the massive presence of alcohol or illicit drugs might be entirely masking a subtle, fatal, underlying traumatic injury.
We are talking about the slow bleed, an intracranial hemorrhage. Perhaps their head struck the steering wheel before the airbag fully deployed, causing a slow subdural hematoma.
Or perhaps there is massive internal bleeding in their abdomen from the kinetic force of the seatbelt.
Exactly. This is where clinical vigilance saves lives and careers. If the patient refused or physically could not complete a breathalyzer test at the crash scene, your index of suspicion must remain sky high.
You simply cannot safely attribute a depressed level of consciousness solely to alcohol if you know they have just been involved in a high kinetic impact event. Alcohol intoxication does not cause focal neurological deficits.
Okay, let's challenge the practical application of this. I understand the textbook theory. But if I have a 250-pound man who is swearing at me, fighting the officers, and stinking of whiskey, how do I practically manage this risk?
The officers want to throw him in a cell to sleep it off.
Yeah.
What is the strict medical legal discipline required of me in that exact moment?
Right, what do you do?
The discipline is strict, structured, neurological monitoring, and physical rousing. It is non-negotiable. You absolutely cannot just look through the little glass hatch of the cell door, see that his chest is rising and falling, and declare him safe to sleep it off.
A dying brain can still command the lungs to breathe until the very end.
You, or the specialized custody staff acting under your direct, documented medical guidance, must physically enter that cell at mandated intervals, often every 30 minutes. You must physically wake the patient up. You must apply a painful stimulus if necessary, like a trapezius squeeze.
You must rouse them to formally check their Glasgow coma scale for deteriorating consciousness.
Are they orientating to time and place or just grunting? Are their pupils equal and reactive to light, or is one pupil suddenly blown and fixed due to rising intracranial pressure?
If they drop a single point on their GCS, or if they cannot be fully roused to a communicative state, they are no longer a drunk driver in a cell. They are a critical head trauma patient, and they require an immediate blue light ambulance transfer to an emergency department for a CT scan.
Missing a masked head injury leads to a completely agonizing, avoidable death on a cold floor, and it will rightfully lead to severe regulatory and legal penalties, potentially manslaughter charges, for the healthcare professional who lazily assumed the symptoms were just the alcohol.
That is arguably the most high-yield clinical takeaway of this entire discussion. Do not let the alcohol blind you to the trauma, the RTC masking effect.
It's a lifesaver.
Now, moving from blunt force trauma to microscopic threats, the source also touches on some incredibly modern, almost sci-fi level emerging toxicology threats that are currently reshaping protocols in the custody suite.
Yes, the global landscape of illicit substances is evolving at a terrifyingly rapid pace, presenting highly novel dangers not just to the physiology of the detainee, but directly to the physical safety of the medical and police staff.
The text mentions the historical presence of anthrax spores contaminating batches of heroin used by intravenous drug users, which is rare but horrifying, requiring massive public health coordination.
But the truly pressing daily issue right now is the exponential rise of ultra-potent synthetic opioids, specifically analogs like fentanyl and carfentanil.
This fundamentally shifts the paradigm from purely patient care to a direct scene safety issue. These synthetic substances are engineered to be so unimaginably potent that literally microscopic amounts, a few grains resembling table salt, can be lethal if inhaled or absorbed.
Detainees who are internally concealing these drugs, or police officers who unexpectedly encounter powdered caches during a physical search of the suspect's clothing, are at extreme immediate risk of accidental fatal exposure.
The healthcare professional in the custody suite now has to constantly factor in environmental force protection and their own safety alongside their clinical assessment of the patient. You don't just rush in to do CPR on a collapsed detainee with white powder on their shirt. You have to consider the environmental hazard first.
And complicating the toxicology even further, we have the explosion of NPS, novel psychoactive substances.
These were previously and inaccurately called legal highs, things like synthetic cannabinoids or spice.
These lab-created synthetics act on the brain in wildly unpredictable ways. They make standard toxicological assessment incredibly difficult because they often don't trigger positive results on standard rapid urine drug screens.
Furthermore, their clinical toxidromes are chaotic. They can mimic multiple different acute psychiatric emergencies, severe hyperthermia, or bizarre neurological deficits, changing from batch to batch.
Which segues perfectly into recognizing that the custody environment isn't always just a place of danger. Sometimes, paradoxically, it is the only safe place for a detainee to finally speak up. Let's look at the dark but necessary reality of cruel, inhuman, and degrading treatment and torture.
This is a deeply sobering reality for the clinician to confront, the concept of the custody cell as a sanctuary.
It sounds like a profound paradox, a locked concrete room acting as a sanctuary, but consider the population.
For an individual who has successfully fled an oppressive, violent foreign regime, or a young person who has been brutally trafficked into the country for forced labor or sexual exploitation.
Or someone who is enduring horrific systemic domestic abuse at home. The austere medical examination room inside a police station might literally be the very first time in their life they are entirely alone, behind closed doors, with an independent, educated professional who is legally and ethically bound by a duty of care.
The source text states this is a critical, fleeting opportunity. The clinician must train themselves to be hyper-vigilant. You aren't just looking for the scraped knee from the arrest. You are looking for the faded, circular scars of cigarette burns, the distinct patterned bruising of defensive wounds, the signs of extreme malnutrition indicating human trafficking.
Or the devastating physical evidence of forced marriage or female genital mutilation, FGM.
It instantly shifts your professional role. You are no longer simply a doctor assessing fitness to detain. You are suddenly acting as a frontline agent for global human rights.
The specific medical and legal framework we rely on globally in these heavy situations is known as the Istanbul Protocol, which is detailed extensively in Chapter 8 of the Simpson text.
Conceptually, it acts as the absolute gold standard for properly and rigorously documenting and investigating allegations of torture.
It ensures that the physical scars and the complex psychological evidence are recorded in such a standardized, objective, and legally sound manner that your medical notes can later be utilized as direct evidence in international human rights courts or complex asylum proceedings.
It is a powerful reminder that the scope of clinical forensic medicine is not just about the law. It is incredibly broad, deeply human, and protective.
Okay, let's transition to the climax of clinical acuity in this environment.
Here's where it gets incredibly intense, and arguably where the most terrifying medical drama in custody takes place. We need to talk extensively about excited delirium syndrome, known as XDS, or acute behavioral disturbance, known as ADD.
This presentation is a classic triad of danger scenario. It is a terrifying clinical cascade that frequently results in highly publicized, unexpected deaths.
These deaths typically occur immediately post-exertion, and the presentation is characterized by highly bizarre, agitated, or violent behavior, the necessary application of heavy police restraint to control that behavior, and usually profound underlying illicit drug intoxication.
The clinical presentation detailed on the rapid reference pocket cards provided by the source is just terrifying to imagine encountering.
Let's list these signs meticulously, because if you are a clinician and you see this cluster, your brain needs to instantly pivot. We are looking for superhuman strength, and we don't mean they are just strong. We mean strength wildly out of proportion to their physical build, requiring multiple large officers to restrain a small individual.
We are looking for atraumatic glass breaking bar. They will punch or smash through thick glass windows without seemingly registering the severe pain or the resulting lacerations.
The sensory processing is completely hijacked.
You'll also frequently see an intense, bizarre attraction to bright lights or loud sounds, or sometimes keening, which are repetitive, unintelligible, almost animal-like noises.
Autonomically, you will see profuse dripping, sweating, and extreme hyperthermia. They are literally burning up from the inside, hot to the touch, and they will often strip entirely naked in public to attempt rapid self-cooling.
And perhaps the most dangerous sign of all, an absolute unnatural inability to tire. Despite massive, prolonged physical exertion fighting against heavy restraints, exertion that would exhaust a professional athlete in minutes, they simply keep fighting.
What's deeply fascinating and terrifying is the pathophysiology here. How does this specific combination of bizarre behaviors actually cause sudden cardiac arrest and kill a physically fit adult?
The exact pathogenesis is highly controversial in the medical literature, but it is undeniably multifactorial. You're watching a perfect, lethal physiological storm unfold. First, you have severe drug toxicity, almost always massive doses of sympathomimetic agents like crack cocaine or crystal methamphetamines.
These drugs block the reuptake of dopamine and serotonin, pushing the central nervous system into absolute overdrive.
Second, you have severe hyperthermia resulting from the continuous muscle contraction. When the body temperature climbs high enough, cellular proteins literally begin to denature, and the muscle tissue begins to break down, a condition called rhabdomyolysis.
This floods the bloodstream with myoglobin, which clogs the kidneys, leading to rapid renal failure.
Third, you have catecholamine-induced fatal arrhythmias. The brain is dumping so much adrenaline into the bloodstream that the heart muscle simply becomes too irritable. It begins to beat chaotically in ventricular fibrillation until it simply stops pumping blood.
And finally, the fatal catalyst, positional asphyxia.
Positional asphyxia directly resulting from the police restraint itself.
Exactly. The police, faced with an individual exhibiting superhuman violent resistance who is a danger to the public, use overwhelming physical force to safely restrain the individual. This often involves pinning the suspect face down on the ground, sometimes with weight applied to their back to secure the handcuffs.
However, this specific prone position physically prevents the diaphragm from moving effectively downward to expand the lungs. You are essentially mechanically starving an already hypermetabolic, oxygen-starved body of the very oxygen it desperately needs to survive the catecholamine storm.
The combination of massive oxygen demand and restricted oxygen intake is rapidly, suddenly fatal.
The text notes a very specific nomenclature shift here that's highly important for our international listeners and for student sitting exams. The U.S. Emergency Services and medical examiners have long used the overarching term excited delirium syndrome, or XDS.
But the medical and legal community in the UK strongly prefers the term acute behavioural disturbance, or ABD.
Yes, the terminology is heavily debated. The UK system actively avoids utilizing the single diagnostic label of excited delirium at autopsy. There is a concern that a single label can obscure the complex mechanics of the death.
Instead, UK pathologists prefer a narrative-style cause of death that lists the multiple contributing factors, for example, cardiopulmonary arrest following extreme exertion and illicit drug toxicity during prone restraint.
This narrative approach avoids oversimplifying a highly complex death. However, whether you write XDS or ABD on your chart, the immediate life-saving clinical action required from the doctor remains absolutely identical.
And that leads to the crucial clinical differentiation for anyone working in this chaotic field. How do you, as a doctor or a nurse, tell the difference between a highly aggressive criminal suspect who is just violently resisting arrest because they don't want to go to jail and a patient who is actively experiencing the physiological meltdown of XDS or ABD?
The mechanism of their presentation dictates your action. The moment you identify the specific cluster of autonomic signs, the profuse inappropriate sweating, the terrifying insensitivity to severe pain, the hyperthermia, the non-tiring relentless exertion, you must instantly pivot your psychological mindset.
If you suspect it is XDS or ABD, you must declare it a profoundly severe medical emergency. It is no longer a law enforcement problem. It is a critical medical crisis masquerading as a public order offense.
The protocol response must be immediate and aggressive. It requires urgent medical sedation, often utilizing rapid-acting agents like intramuscular ketamine or midazolam, to chemically break the catecholamine surge and stop the muscle breakdown.
It requires the immediate removal of unnecessary sensory stimuli. You command the officers to turn off the blaring police sirens, kill the flashing strobe lights, and clear the room of shouting people.
And most importantly, it requires immediate rapid transport in an ambulance to a hospital emergency department with full advanced resuscitation capabilities. You do not, under any circumstances, leave a patient exhibiting signs of ABD in a locked police custody cell to calm down. They will die.
Never. Recognizing that critical pivot from viewing the individual as a hostile suspect to recognizing them as a dying critical patient is exactly what saves lives. Which leads us seamlessly to our final core conceptual area, the overarching goal of all this medical presence, the prevention of death and harm in police custody.
Because tragedies in custody are catastrophic. They deeply traumatize everyone involved, the grieving families of the deceased who demand answers, the police officers who have to live with the outcome, and the medical staff whose clinical decisions are placed under a microscope.
Prevention relies heavily on intersecting systems: environmental design, robust technology, and, most importantly, highly specific medical training for non-medical personnel.
Let's touch on that training aspect, particularly regarding the physical mechanism of injury for positional asphyxia we just discussed. It is crucial that police officers understand why their physical tactics can be lethal. Why does kneeling on a suspect's back or utilizing certain vascular restraint holds around the neck turn fatal so rapidly?
When you combine profound physical exhaustion from a foot chase, drug-induced respiratory depression from opioids, and external mechanical pressure on the chest wall restricting the diaphragm, the physiological margin for error drops to absolute zero.
Educating police officers on these exact physiological mechanics fundamentally changes their use of force tactics on the street. They learn to move the suspect off their stomach and into a seated or recovery position the absolute second the handcuffs are secured. Prevention starts before they even reach the station doors.
And once they are inside the station, we have specific environmental and technological safeguards designed to mitigate risk. The visual sources provided alongside the text illustrate this perfectly. Modern custody suites are heavily equipped with specialized, continuous CCTV monitoring, especially focusing on cells housing individuals flagged during the risk assessment as high self-harm risks.
But honestly, my favorite detail in the environmental design, because it is so starkly pragmatic, is the ligature knife.
It is a vital, non-negotiable piece of safety equipment. A ligature knife is a specialized, brightly colored, usually yellow tool. It features a deeply recessed, shielded hook blade. All jailers, detention officers, and custody staff must physically carry it on their person at all times, attached to their uniform or keys.
Its single grim purpose is to allow staff to instantly, safely, and rapidly cut down a suspended detainee who has attempted suicide by hanging with a makeshift ligature, like a shoelace or a torn blanket. The recessed blade design ensures they can quickly hook and sever the material without risking further accidental laceration injury to the panicked patient's neck, which would be highly likely if they were frantically using open scissors or standard pocket blades.
It's a grim, stark reality, but carrying that specific tool on your belt shows a systemic institutional acknowledgement of the omnipresent risk of suicide in this environment. We also see the increasing integration of life signs monitoring devices built directly into the cell designs, utilizing radar or optical sensors to track respiration rates of sleeping detainees.
Those technological advancements are impressive, but I must provide a critical clinical caveat here. Technology is merely a tool. It is not a complete solution. A life signs monitor can successfully alert the front desk to a sudden cardiac arrest, but a camera lens cannot perform life-saving chest compressions.
The Simpson text sternly and rightly notes that technological monitoring is never an acceptable substitute for appropriately staffed, fully trained healthcare professionals and custody officers who are physically present, engaged, and highly skilled in basic life support, airway management, and CPR.
The human element, the trained clinical eye noticing a subtle change in skin tone or breathing pattern, remains the ultimate, irreplaceable safeguard.
Okay, we have covered an immense amount of complex, high-yield ground today. We've navigated the intersecting vulnerabilities of the custodial population, the absolute ethical necessity of clinical independence, the lethal physiological traps of withdrawal and RTC masking, and the terrifying hypermetabolic reality of acute behavioral disturbance. Let's actively lock this knowledge into your long-term memory.
We are transitioning to our rapid recall learning reinforcement section.
I'm going to read a series of single best answer style prompts specifically designed to mimic the traps and distractors examiners use to test these concepts. I will read the prompt, I'll pause briefly to give your brain a second to commit to an answer, and then the expert will provide the definitive clinical answer and tell you exactly which conceptual section of Chapter 16 you should revisit if you struggled. Ready? Let's lock it in.
Let's do it.
Question 1. What is the fundamental defining difference in the medical scope of practice between a practitioner of clinical forensic medicine and a forensic pathologist?
Answer. The foundational difference is the patient state. Clinical forensic medicine involves the living, for example, actively assessing a breathing detainee's fitness for police interview or meticulously documenting their fresh assault injuries. Forensic pathology deals exclusively with the dead, determining the precise cause and mechanism of death via autopsy in a mortuary. If you miss this, revisit the core concepts surrounding healthcare in police custody.
Question 2. You examine a detainee in a cell. You observe frequent yawning, visible piloerection or goose flesh, a resting tachycardia of 115 BPM, and the patient complains of severe, deep bone aches. Which specific clinical assessment scale is most appropriate to utilize here, and what precise physiological condition are you quantifying?
Answer. You must utilize the CIWS, the Clinical Opiate Withdrawal Scale, to objectively assess and quantify the severity of acute opiate withdrawal. These are hallmark signs of sympathetic rebound following opioid cessation. If you are confused by the distractors, revisit the section detailing the nature of health problems of detainees.
Question 3. A detainee is brought into the custody suite following a high-speed RTC where they struck a tree. They are violently slurring their words, extremely drowsy, and their breath smells overwhelmingly of alcohol. What critical, potentially fatal clinical pitfall must the healthcare professional actively prevent during their ongoing monitoring?
Answer. The clinician must actively prevent the RTC masking effect. You must avoid the fatal trap of failing to recognize a severe underlying traumatic injury, such as a slow-bleeding intracranial subdural hemorrhage, simply because the obvious neurological symptoms are falsely and entirely attributed to alcohol intoxication. Regular physical rousing to assess the Glasgow Coma Scale is absolutely required. For consolidation, review deaths and harm in police custody.
Question 4. Police bring a suspect into the suite. The suspect is exhibiting profuse, inappropriate sweating. They required 4 officers to restrain them due to superhuman strength, and they recently punched through a glass window without showing pain. What is your immediate, overarching medical management priority?
Answer. You must instantly recognize this specific behavioral cluster as an acute behavioral disturbance, ABD, or excited delirium syndrome, XES. You must immediately pivot to treating this as a profound, life-threatening medical emergency. It requires urgent medical sedation to halt the catecholamine surge, immediate removal of sensory stimuli, and rapid ambulance transport to a hospital equipped for full advanced resuscitation. It is not a disciplinary issue. Revisit the specific criteria under excited delirium syndrome.
Question 5. When analyzing epidemiological data regarding mortality in the custodial setting, which of the following is not considered one of the 3 most common preventable causes of death? Self-harm, sudden natural disease, severe alcohol withdrawal, or acute drug intoxication?
Answer. Sudden natural disease. While acute natural disease, like an unpredictable massive heart attack, is one of the main causes of death overall, self-harm, severe alcohol withdrawal, and acute drug intoxication are specifically identified clinically as the most common preventable causes through timely medical intervention. If you struggled with this distinction, revisit deaths and harm in police custody.
Brilliant. That anchors those core frameworks beautifully. Thank you so much for joining us on this extensive deep dive. As always, before we sign off, we want to leave you with a final provocative thought to mull over as you return to the library, your textbooks, or your clinical rotations.
Consider this broader perspective. If the modern police custody suite constantly acts as the ultimate unforgiving stress test for our society's overlapping systemic crises of severe addiction, unmanaged mental health, and neglected chronic illness, then the locked concrete cell is no longer just a legal holding pen for suspected criminals. It functions as a harsh, unfiltered diagnostic mirror. It perfectly reflects the exact points where our broader public health safety nets, our community clinics, and our social support systems have completely failed, long before the metal cuffs ever clicked shut on the street. As a clinician stepping confidently into that highly scrutinized space, you must recognize that you are often forced to acutely treat the end-stage symptom of a much, much larger societal disease.
That is an incredibly powerful, sobering perspective to carry with you into your practice. It reminds us of the humanity at the core of forensic medicine. Now, the responsibility is over to you. Go open your book. Read Chapter 16 of Simpson's Forensic Medicine to complete your learning and firmly solidify these conceptual frameworks. Until next time, stay curious, stay clinical, and keep learning.